Good morning, all. Today, our lecture will be on wounds and wound healing. And we'll start with wounds before describing wound healing. And wound is defined as the disruption of the structural and functional integrity of a tissue. This disruption depends on the extent, of the causative agent. So the more the impacts of the causative agents, the more the extent of the wound. And the causes of wounds could be mechanical, that results from injury from work, mechanical trauma resulting into development of injury or wounds, and it could be from chemical agents. These chemical agents could either be acids, alkali, or other caustic agents. Or corrosive. Usually, acids can cause coagulative necrosis. They cause coagulative necrosis burns, while alkali causes liquefactive necrosis. There are some other corrosive agents that can cause chemical injuries. Okay. Now, radiation injury exposure to ionizing radiation can lead to tissue damage. And usually, this tissue damage results from destruction of microcirculation. And when there's destruction of microcirculation, you have ischemia and necrosis of the part involved. This process is called endarteritis obliterans. And pathogenic organisms by tissue invasion can cause inflammation and subsequent injury. So these are common causative agents, which could be mechanical from external forces or trauma, chemical agents that are either caustic corrosive, they could be alkali or acids. And we said acid causes coagulative necrosis, while alkali causes liquefactive necrosis. And the implication of that is usually acid burns or acid injuries are more superficial than alkali burns because it coagulates and causes a form of scarp that prevents further penetration, while in alkali, it causes liquefactive. The extent of penetration is deeper than acid burns. Radiation as well as pathogenic organism from tissue invasion by pathogenic microorganisms. Now, wounds, there are various ways of classifying wounds. Wounds could be classified as closed wound or open wound. When you say a closed wound, it means there's an intact epithelial surface. The closed wounds could either be contusion. Examples of closed wounds are contusion or bruise. Bruise and contusion is one and the same thing. Is injury to tissue subendothelial to surface epithelium, usually from blunt trauma. So when there's a blunt trauma and disruption of microvessels in the subendothelial region leading to bleeding, this is called bruise or contusion. I found some candidates confusing bruise with abrasion, which we'll see shortly. So bruise, the epithelial surface is intact, while in abrasion, there is loss of epithelial surface. So in other words, bruise is a closed wound, while abrasion is an open wound, which we'll see shortly. So bruise is contusion, and it results from subendothelial soft tissue injury. And hematoma is also a closed wound. It's a localized collection of blood outside the blood vessels, either a liquid or clotted form within the tissue. So this hematoma is not in continuity with the circulation. It has excited and collected outside the effective circulating space. And of course, when this hematoma is in the subcutaneous tissue and more than 1 centimeter, it is called ecchymosis. So these are the two examples of a closed wound. Now, in open wound, there is break or disruption of the skin or epithelium. And there are various forms of open wounds. Incision. In incision, a wound is created with sharp instruments. And it's usually during surgery where you make surgical incisions with your scalpel, or it could be from razor blade, a sharp object like razor blade, a cut from glass or knife. And usually incisions, the wound is longer than deep, okay? And the edges are clean, okay? And you see the significance of these as compared to laceration. So you should know in incision, the edges of the wound are clean and may be well apposed. In abrasion, there is loss of superficial layers of the epithelium. It is due to friction with hard and rough surface. This is what I was trying to differentiate from bruise, where the layman confuse a bruise with an abrasion. So in medical terminology, bruise and contusion are the same, while abrasion is from friction injury or friction burns that leads to loss of the superficial layer of the skin. Laceration. Laceration is irregular tear-like wound, okay, caused by some blunt or sharp instrument. It's usually contaminated with ragged edges. You can see the difference between incision and laceration. In laceration, the edges are ragged, while in incision, the edges are smooth and clean, okay? Laceration has a ragged edges, okay? And the edges have a lot of devitalized or dead tissues. It has the length, the width, and the depth of the laceration, and the extent of these laceration depends on the impact of the causative object. It could be a mild or superficial laceration. It could be deep, or it might even be extensive with associated avulsion of or even degloving of the tissue. Now, avulsion injuries they are injuries in which a body part is forcefully detached from its normal point of insertion. So you have detachment of tissue, which could be complete detachment, that is complete avulsion, or it could be a partial avulsion where there is detachment and some tissue is still at connecting the avulsed tissue to the body. Okay, and when you have an incomplete or partial avulsion where it is connected to the body by a tendinous or strand of connective tissue, it might still contain blood vessels that is feeding that avulsed part, and the bleeding will continue profusely. So avulsion could either be complete avulsion or a partial avulsion, which is forceful detachment of a body part. Avulsion can go to an extent of degloving. You remove, there's detachment of the skin and subcutaneous tissue from the underlying muscles, tendons, and bones. You just have a degloved section of that tissue. Now, puncture. A puncture wound is caused by a pointed tip instrument with a small entry. Example, nail puncture. Yes, penetrating or perforating wound. Now, in penetrating wounds, the penetrating wounds enter a body cavity, such as the chest, abdomen. When an object enters, a sharp object enters into a body cavity, that is a penetrating wound. And what you need to know about a penetrating wound is the injury are deeper, okay, than longer. If you have a body cavity and a sharp object penetrates this cavity, okay, you have a deeper than the length. So the danger of this, it passes through an organ, it passes into a cavity and cause injury to internal organs. Now, when you have a penetrating injury, it injures internal organs, accumulate a lot of bleeding within the organ or cavity. While a perforating wound enters through and through an injury, it's a true and true injury. Okay, it enters a cavity and also exits. Okay, you can see penetration enters a cavity, perforation enters and exits a cavity. So that is a perforating wound. Perforating wounds entirely pass through an organ or cavity and are characterized, they are characteristics of firearms or missile injury. Now, because of the peculiarity of gunshot injury, gunshot wounds are a category on their own because of certain peculiarities. You don't just categorize them as a perforating, penetrating wound. You can describe a gunshot as a penetrating gunshot injury, but it's a category on its own because of certain peculiarities. Now, gunshot is caused by a bullet or similar projectile driving into or through the body. Okay, they may be entry and exit wound when it completely perforates the body, or an organ. Usually the exit wound appears larger than the entry wound. And the kinetic energy for the movement of a trajectory bullet injury is determined by the mass and the velocity of the bullet. You see, it means when you have a heavier bullet, the kinetic energy of that impact is more, as well when you have the bullet moving with a higher velocity, the impact is higher. This is gravity. So it means you have long guns or missile have greater impact than shotgun because of this kinetic energy. In kinetic energy, the bullets have higher masses as well as the velocity is higher. Okay, so gunshot wounds, the damage they cause is from the direct impact on the body, the shock wave it generates, and there's the concept of temporary cavitational effect caused by the moving bullet, as well as a shattered fragment of bone can spike or tear or lacerate a nerve. Direct impact, shock wave, cavitary effect if you have a bullet moving through a body cavity, through a tissue. Okay. This bullet, as it moves, it moves in a trajectory manner. Not that it just goes in a straight line. No, the bullet moves in a trajectory manner. So as it moves in this manner in the tissue, one, it generates a lot of waves. It causes a temporal cavity. When the bullet passes, there's a temporal cavity. So these two effects cause harm or destruction of tissue far away from the site of the injury. So it causes cavitary effects. The cavitary effects and the shock wave it generates cause injury not only at the point of impact, but to some distance from the sites of the impact of the injury. So this is the cavitary effect. That's why you have impact on a particular site. And of course, there's more injuries at a more distant site because of its cavitary effect. You can see it forms temporal cavity. And within this cavity, you have a lot of necrotic devitalized tissue, and there will be accumulation of blood within this cavity. So in gunshot wound, you don't suture primarily, because when you suture primarily, it will accumulate a lot of blood, and there are a lot of devitalized tissue in that cavity, which will get infected and cause further harm. You can see gunshot injury is peculiar, and it has its own naming or classification. So you can say a penetrating gunshot injury because of this its own feature or its own peculiarity. These are all examples of open wound. We said closed wound could either be contusion or bruise or hematoma, and closed wounds are either incision, abrasion, laceration, avulsion, puncture, penetrating or perforating wound, gunshot wound. That is a way of classifying wounds. Wounds can also be classified as acute or chronic wound. You see, in acute wounds, they heal in a predictable manner and time frame. They follow the normal sequence of wound healing, and they are healed in an expected time frame. The process occurs with few, if any, complications, and the end result in a well-healed wound. But in a chronic wound, they do not follow the orderly sequence of wound healing, okay? A chronic wound is a wound that does not heal in an orderly set of stages and in a predictable amount of time, the way most wounds do. So any wound that will exceed 3 months is regarded as a chronic wound. Example, a chronic leg ulcer. You see, there are sequences, complex process, which we will see of normal wound healing. If there is impairment of any of these stages or processes, it transforms into a chronic wound, or when there's a prolongation of one of the stages of the wound healing, it becomes a chronic wound. Wounds can also be classified as simple or complex wound. In simple wounds, only the skin is involved, while in complex wounds, vessels, nerve, tendons, and bones are involved. Now, there's the Rank and Wakefield classification of wounds into tidy and untidy wounds. Tidy wounds are surgically incised wounds. They are clean, they have healthy surrounding tissue, and there's seldom tissue loss. There's hardly any tissue loss. And the significance of these, they heal by primary intention. While untidy wounds, they are dirty wounds that result from crushed or avulsion injuries. There are a lot of devitalized tissue. They are contaminated, and they are associated with tissue loss. Most of the time, untidy wounds, when they become infected, okay, when they are not managed properly. Now, the surgical wounds are classified into clean wound, clean contaminated wounds, dirty wounds, contaminated wounds, and dirty wound. This classification is based on the degree of contamination and the risk of infectivity. Now, clean wounds are surgically incised wound. There is no breach of asepsis, okay? And the risk of infection is less than 1 to 2%, okay? Now, clean contaminated wound, okay? Now, in clean contaminated wound, what happens here is it's also a surgically incised wound. However, during this incision, there is breach of asepsis, okay? There is breach of asepsis. Maybe you are not using sterile gloves, you are not using sterile instrument. So it's clean, contaminated. It is contaminated, and the risk of infection is 5 to 10%. Okay. Now, in contaminated wounds, before even making incision, there's an infection. Okay. Example, if you are making incision on an abscess cavity, you know there's already an infection going on. Maybe trauma injuries, there will be contamination from the surrounding. So that is a contaminated wound. And the risk of infection is up to 10 to 15, 10 to 30%, while dirty wound is more than 30%. Okay. So these surgical wounds are classified based on two factors. One, we said the risk of infectivity, and two, based on the degree of contamination. So you can see these are the various ways wounds are classified. And classification of wound is very significant in the management of wound, because if you have a dirty wound, the way you treat a dirty wound is different from the way you treat a clean wound, because dirty wound has a lot of devitalized tissue in which you have to debride. You do a debridement, okay, for the wound to heal properly. While clean wound, there is no need to do any debridement. Okay, so now we are going to talk about wound healing. Now, wound healing is the replacement of damaged tissue by a living one. Okay, when a dead tissue is replaced by a living one, is regarded, that is what wound healing basically entails. And it involves an organized and complex cascade of cellular and biochemical events. When you talk about healing, it means you are restoring, okay, the structure and function. So as we said, wound is the disruption of the structural and functional integrity of a tissue. So the wound healing is the restoration of that structure and function. And this process is achieved by the healthy living tissue. Okay. Now, what are the types of wound healing? Traditionally, there are three types, but of course, you can see there are four types of wound healing. Okay, here. Now, the first type is called primary healing by primary intention. Healing by primary intention. It occurs in a clean wound when closure of a wound is done within hours of its creation. When you make an incision, surgical incision, that is a clean wound, and the edges are well apposed. There is no tissue loss. So that wound is going to heal by primary intention, and this is facilitated by sutures. Okay, when you suture the edges together, it facilitates primary healing. There is no or minimal formation of granulation tissue. There is no tissue. It doesn't need tissue contraction because the edges are well apposed. So it just heals by primary intention. And this is facilitated when you use sutures or clips to put the edges together. Okay. So the next type of wound is called wound healing, is called healing by secondary intention. It occurs when the wound edges are not approximated or when gaping occurs. There is tissue loss here. You should know in healing by primary intention, there is no tissue loss. The edges are apposed. While in healing by secondary intention, the edges are not approximated because of tissue loss. So it requires closure. Wound closure requires contraction. They have to be wound contraction so that they come together. Okay. Yes. Now, here, let me demonstrate that to you. In healing by primary intention, you have the edges are opposed together. So there's just all the process of healing takes place within this incision site, and you can further enhanced it by putting a suture to close the wound. Okay. Now, in healing by secondary intention, you see this one of the edge, you have tissue loss here. So it requires wound contraction to reduce the space for healing to take place. Okay. So that is what healing by secondary intention entails. Okay. So after that contraction, of course, the surface needs to be epithelialized by normal epithelium. Now, you should know when there is healing by secondary intention, there is formation of scar. Because since there is tissue loss, it cannot be replaced by the healthy tissue. You only have fibrosis. Fibrous tissue tend to replace that space. So you have more scar formation. And of course, if it is infected, you have an ugly scar. Okay. So healing by tertiary wound healing or healing by tertiary intention. What does it entail? Healing by tertiary intention involves initial debridement of the wound for an extended period, okay, and then formal closure by another mechanism like skin grafting or flap cover. So when you say healing by tertiary intention, it involves use of either graft or flap to cover a wound, to cover a defect. Then you allow the wound to heal. That is healing by tertiary intention. Of course, if the wound is dirty initially, you have to what? You have to debride and devitalize. Now, this brings us to the term delayed primary wound healing. Okay, delayed primary wound healing. Okay. When you say delayed primary wound healing, at presentation, that wound has a lot of edema, okay, or features of infection. You want edema to subside in about 3 to 5 days, then you now close primarily. When a patient presents with a wound and you see some features of inflammation, or that wound has exceeded the golden hours, which is 6 hours, 6 to 8 hours of injury, you don't want to close primarily. So you allow edema to subside so that the wound doesn't break down. So that process of allowing edema and infection to subside is called delayed primary closure or delayed primary wound healing. Now, healing by quaternary intention. Healing by quaternary intention usually occurs in the donor site. You know, when you are grafting a tissue, there is the donor site where you harvest skin and you place on the recipient site where there is defect. Okay, so you should know that when you harvest tissue from a donor site, if you remove the skin, there are some skin appendages like the sweat gland, sebaceous gland that are still on the donor site, and you have regeneration of epithelium from that donor site. Okay, you have regeneration of epithelium from that donor site in order to close that defect you left. That is called quaternary intention. So you have epithelialization from the skin appendages of that donor site, like the sweat glands, the sebaceous gland, and this epithelium migrates to cover the surface of that donor side. That is healing by quaternary intention. Okay. So we've seen the various types of wound healing. Now we'll talk about the phases of wound healing. Generally, there are 3 phases of wound healing. Okay. The phases are the hemostasis and inflammation, the proliferative phase, and maturation and remodeling phase. Now, the hemostasis and inflammatory phase of wound healing occur immediately, and it takes up to 3 days. You can see we're talking about types of wound. We talked about acute and chronic wound. Sometimes these phases are prolonged, making the wound transforming into a chronic wound. Instead of having an inflammatory phase that should last for up to 3 days, it's taking 1 week or 2 weeks because of a factor that is preventing or preventing healing or prolonging the inflammatory phase. For example, there's a foreign body there. It's going to prolong the inflammation. There's infection there. It's going to prolong the inflammation. Hence, that wound will transform into a chronic wound. So, hemostasis and inflammation, or the inflammatory phase, you have the proliferative phase, then the maturation and remodeling phase. The proliferative phase is the phase of tissue regeneration, and it takes about 1 to 6 weeks. And the maturation phase is the phase of strengthening, acquiring tensile strength. Okay. And it's all about collagen deposition, as well as alignment or laying of collagen along the pattern of stress of that region. Now, when an individual sustains injury, the first process is to limit blood loss from that injury, which is the stage of hemostasis. Okay. And the hemostasis is achieved by 2 processes: vasoconstriction, as well as formation of temporal hemostatic plaque from platelet aggregates. Now, initially, after injury, there is a normal vascular and cellular response to injury. The vascular response is vasoconstriction, and this vasoconstriction lasts for about 5 to 10 minutes. Okay. When this ensues, it's mediated by epinephrine, norepinephrine, prostaglandin, serotonin, and thromboxane. The aim of this vasoconstriction is to reduce hemorrhage, and it aids in platelet aggregation, because if there is vasoconstriction, okay, you have, okay, and there's crowding of the cells there, it will aid platelet aggregation and keep healing factors within the wound. If there's vasoconstriction, there will be the blood will not flow out of that area, which will aid platelet aggregation, and it will also aid release of substance. So that is the vascular response. Now, what happens at the cellular response in the hemostatic phase? Now, you should know there is damage of endothelial cells during tissue injury, and the damaged endothelial cells retract to expose the subendothelial collagen. The subendothelial collagen surface is exposed, and there is aggregation of platelets to the subendothelial collagen. And this adhesion of the platelet to the subendothelial collagen is through adhesive glycoproteins. These are factors that aid this adhesion. Fibrinogen, fibronectin, okay, thrombospondin, and von Willebrand factor. Von Willebrand factor is very important in platelet adhesion to exposed subendothelial collagen. Okay. Now, what happens next? The aggregation of the platelet results in formation of a primary platelet plug. And when when these platelets forms an aggregate, they become what? Activated when they are exposed to collagen. And you require platelets to be activated for degranulation of substances within their alpha granules. So you require activation of platelet for degranulation of substances that are contained within the alpha granules. Activation enables platelet to degranulate and to release chemotactic agents and growth factors, because for inflammation to set in, because we say the first stage is hemostasis and inflammation. For inflammation to set in, the platelets must release substances that will draw or attract inflammatory cells to the site of the injury. These factors are platelet-derived growth factors, proteases, vasoactive agents like serotonin and histamines. Now, this leads to what? The inflammatory phase. As we said, platelets are the first response cells. They release multiple chemokines, including epidermal growth factors, fibronectin, fibrinogen, histamine, platelet-derived growth factors, serotonin, and more von Willebrand factors that even further the adhesion to the collagen. This helps to stabilize the wound through the clot it forms, and also these mediators act to control bleeding and limit the extent of injury. And they also attract inflammatory cells, specifically the macrophages. The next cells present in the wound are the leukocytes and the macrophages. Okay, the macrophage is referred, okay, as the orchestrator and is essential for wound healing. Now, macrophages play important role in what? Phagocytosis, wound debridement, release of further growth factors which activate fibroblasts and endothelial cells. Now, these macrophages come in to the site of the wound, okay? Of course, along with other inflammatory cells like the neutrophils and so on. But the main orchestrator of this wound healing is the macrophages. They engulf bacteria, they devitalize dead tissues and so on. And they further release substances that will trigger the next phase of wound healing, okay? So what are the main substances they produce and what other cells they want to stimulate? You know, it is the fibroblasts and the endothelial cells play significant role in tissue regeneration. That is the proliferative phase. So the macrophage in the inflammatory phase have to produce substances that will stimulate these cells. Numerous enzymes and cytokines are secreted by the macrophage. These include collagenase, which debride the wound. This is an enzyme that debride, devitalize tissue, interleukins, and tumor necrosis factor, which stimulate fibroblasts to produce collagens and promote angiogenesis, formation of new vessels, and transforming growth factor, which stimulates keratinocytes. This step marks the transition into the process of the proliferative phase. Now, the proliferative phase, the fibroblasts, endothelial cells, and epithelial cells are involved in this phase. Now, the fibroblasts secrete collagen, okay? The endothelial cells, okay, proliferate from intact venules to form capillary buds. Now, both the fibroblasts that form collagen and the new vessels that are formed via angiogenesis form the granulation tissue. And the epithelial cells proliferate from the wound edges to seal the wound. So the proliferative phase is made up of three processes: epithelialization to seal up the wound, angiogenesis, formation of new blood vessels, and granulation tissue formation. Now, there is collagen deposition. These are the principal steps in the anabolic phase of wound healing. Now, the epithelialization occurs early in the wound repair. Now, if the basement membrane remains intact, the epithelial cells migrate upward in the normal pattern. Okay, the epithelial progenitor cells remain intact below the wound, and normal layer of epidermis are restored in 2 to 3 days. That's why after surgical incision, it's a clean wound. Of course, the patient can take his bath after 2 to 3 days because you expect that clean wound to have been sealed, to have been epithelialized. Okay, except if it's a dirty, infected wound where the process of proliferation and epithelialization will be prolonged and, of course, delayed, which might even lead the wound into entering the chronic wound. Now, if the basement membrane has been destroyed, okay, similar to a second or third degree burns, then the wound is epithelialized from normal cells, okay, in periphery and from skin appendages, as we described in the quaternary wound healing, where new epithelial cells are formed from hair follicles, sweat glands. Okay, that is when you have disruption of the basement membrane. Now, angiogenesis is formation of new blood vessels, and this usually is from the endothelial cells that are derived from the venules, okay, of intact tissue, where new capillary buds are formed and they proliferate to form new blood vessels. And this is stimulated by tumor necrosis factor alpha. Is marked by endothelial cell migration and capillary formation. These deliver nutrients and maintain the granulation tissue bed. You see, if there is no adequate neovascularization, there will be no adequate nutrient supply, no adequate oxygen supply to the wound, and the wound healing will be impaired. Okay? So, an adequate angiogenesis is required for a proper wound healing. Now, the granulation tissue phase requires nutrient supply by the capillaries, and failure for this to occur results in a chronically unhealed wound. The final part of the proliferative phase is granulation tissue formation. We mentioned that it is the fibroblasts that deposit collagen. Fibroblasts differentiate and produce ground substance and then collagen. The ground substance is deposited into the wound bed. The collagen is then deposited as the wound undergoes the final phase of repair. Okay? Many different cytokines are involved in the proliferative phase of wound repair. You can see these cytokines, all these mediators are persistently present throughout the process of healing. Now, cytokines include platelet-derived growth factor, insulin-like growth factor, epidermal growth factor. All these are necessary in collagen formation. Now, the growth factors in wound healing include the transforming growth factor, beta, platelet-derived growth factor, basic fibroblast growth factor, epidermal growth factor, okay? Now, of course, there are various functions of these mediators. Transforming growth factor, beta, platelet-derived growth factor, okay? Basic fibroblast growth factor mediates chemotaxis of macrophages and fibroblasts towards the center of the wound where they are stimulated to divide and proliferate. Now, you see, you need to know the function of all these mediators because of multiple choice questions. Platelet-derived growth factor also stimulates secretion of fibronectin, other adhesion proteins, collagenase, essential for restructuring of collagen for cellular migration. Okay? Basic fibroblast growth factor has a role in the formation of new vessels, angiogenesis, and granulation tissue formation. Transforming growth factor beta is involved in what? Wound contraction. You remember we talked about secondary wound healing where there is tissue loss and there is a lot of fibrous tissue formation, so it requires wound contraction. Transforming growth factor is necessary for that. Okay? Epidermal growth factors stimulate epidermal growth, cellularity, epithelialization, and thickness of granulation tissue. Okay? Now, EGF, transforming growth factor beta, platelet-derived growth factors are all they all mediate development of tensile strength of a wound. And tensile strength of a wound is the ability of a wound edge to resist disruption. The higher the tensile strength of a wound, okay, the higher its ability to resist external force, tissue disruption, and the more the edges stay together. Now we'll talk about the maturation phase of wound healing. This is the final phase of wound healing. The wound here undergoes contraction, ultimately resulting in a smaller amount of apparent scar tissue. Now, this maturation phase, you should know the aim of this maturation phase is to increase the tensile strength. The entire process is a dynamic continuum with an overlap of each phase and continued remodeling. Here, what happens here, collagen is deposited. What type of collagen? Type 3 collagen is deposited at first, but over the following weeks, the type 3 collagen, which is less stable, decreases and it is transformed. There is deposition of more stable type 1 collagen. So there's reduction in the amount of type 3 collagen and there's increase in type 1 collagen in a maturing wound. Now, the wound reaches its maximal strength at 1 year with a tensile strength that is 80% of normal skin. A wound never achieves 100% of the pre-injury state. They never achieve a tensile strength of the pre-injury state. You can see up to 1 year, they just achieve up to 80% of their tensile strength. Collagen deposition continues for a prolonged period, but the net increase of collagen deposition plateaus at 21 days. Now, contraction of wound is an ongoing process resulting in part from the proliferation of the specialized fibroblasts termed myofibroblasts. You can see this has some muscle cells. This is a form of specialized muscle fibroblasts that have cells that resemble smooth muscle. So they are abundant in the proliferative and maturation phase where you have contraction of the wound. The wound contraction occurs to a greater extent with secondary healing than in primary healing. Now, you know, the remodeling is just to arrange these collagen in a pattern of stress of that body part. With time, the collagen fibers become thicker and get arranged along the line of stress, leading to an increased tensile strength of the wound. Now, this collagen, what are collagens? They are structural proteins in the extracellular space synthesized by fibroblasts. You have the tropocollagen. It's a precursor. It's a pre-collagen molecule, a helical structure with glycine at the third position, hydroxyproline, which is more abundant, and hydroxylysine. This forms a collagen, and there are some substances that are required for its formation. Vitamin C is required in the hydroxylation of proline and lysine, while copper is required to hydroxylate lysine. There are several types of collagen. However, the 4 common types are type 1, 2, 3, and 4, seen predominantly in the mnemonic scalp. 1 is seen predominantly in the skin. You remember, during the maturation phase, type 3 collagen reduce in quantity, while the type 1, which is more stable on the skin, increases. So you have skin type 1, connective tissue type 3, type 2, or cartilage. Then arteries in blood vessels, you have type 3. You know, during new vascularization, a lot of new vessels are formed. Then you have type 4, which is found abundantly in the basement membrane. So these are the 4 common types of collagen. Now, what are the factors affecting wound healing? The factors affecting wound healing include, they can be categorized into systemic and local factors. They are categorized into systemic and local factors. The systemic factors include age. Of course, you know, wound healing is slow in elderly, okay, due to reduced rate of protein turnover. So you can see wound healing is better in younger than the elderly people because they have less protein synthesis, less protein turnover, more comorbidities that will impact on several metabolic processes in the body. Malnutrition, as you see, there are some certain nutrients that are required in the process of collagen formation. In the process, proteins are required in the process of granulation tissue deposition. So you can see when a patient has malnutrition, protein energy malnutrition, malnutrition of some micro elements and vitamin, they have prolonged wound healing. As you see, vitamin C is required in collagen synthesis. So a patient with deficiency of vitamin C, there will be prolonged wound healing. And of course, during management of wound, you give some supplements, vitamin A, vitamin E, vitamin C. All these are wound healing drugs, as well as zinc, okay, that aids epithelialization. Now, when a patient is involved in trauma, that is, this can be in local or systemic factor. This metabolic response to trauma can cause immunosuppression and it will delay wound healing. Metabolic diseases like diabetes mellitus, okay, they can cause immunosuppression. Yes, both the cellular and humoral immunity is affected, and patient will have reduced wound healing. Example of this is patient suffering from diabetes mellitus, especially uncontrolled diabetes mellitus. Other systemic diseases like uremia will impair wound healing, okay? Because uremia impair platelet aggregation and so many other metabolic processes. Jaundice, liver cirrhosis, as well as malignancies. All these are immunosuppressive conditions. They affect wound healing, or they may have some metabolic aspect that are impairing the healing of wound. Immunosuppression, they might be diseases from retroviral disease, HIV/AIDS, okay? Connective tissue disorder like Ehlers-Danlos syndrome, where you have defective collagen synthesis and deposition, it affects wound healing. Smoking also affects wound healing by impairing and prolonging the inflammatory phase of wound healing, and also it causes persistent vasoconstriction and ischemia of the healing wound. Medications like steroids, cytotoxic drugs are all immunosuppressive drugs, and they inhibit wound healing. Local factors like mechanical injury to the wound will impair, it will disrupt epithelialization and the cascade of wound healing. Immobilization would aid wound healing, because if there's continuous movement, especially in flexural areas, when the epithelialization is formed, it's disrupted. So it will keep on prolonging the wound healing. When there is infection, it will prolong the inflammatory phase and delay wound healing. Edema will also prolong wound healing by impairing blood supply to the site. Ischemia prevent blood supply, oxygen delivery to the tissue. Where you have vascularity, increased vascularity, the wound healing is aided. For example, healing on the head and neck area, the scalp is highly vascularized, and these will aid wound healing. If you have a lot of necrotic tissue in a wound, it will prevent tissue perfusion, and it will enhance bacterial proliferation. That's why you have to do the debridement by removing dead and devitalized tissue. There are some topical agents that may interfere with wound healing. Ionizing radiation will destroy the microcirculation, and of course, it will release a lot of free oxidants that will interfere with wound healing. So when it destroys the microcirculation, delivery of oxygen and nutrient is impaired, and there's prolongation of wound healing. Oxygen tension, foreign body will cause chronic inflammation, and it will progress into a chronic wound. Then excessive tension on a wound. When you put excessive tension on a wound, either by suture, okay, it will impair blood supply to that wound, okay, and it may cause tissue necrosis and a nidus for infection formation, and also it can even cause hematoma. What are the complications of wound healing? The complications of wound healing include keloid and hypertrophic scar formation. You see, keloids are seen in those patients who are predisposed. They have genetic predisposition to keloids. They are abnormal scar formation. You have excessive collagen deposition, and the scar grows above the wound and it grows beyond the edge of the wound. So keloid is an abnormality or a complication of wound healing. Hypertrophic scar does not grow beyond the wound edges. Wound can become chronic if there is a persistent stimulus that prevents the wound from healing. So it can become a chronic wound, chronicity. There could be hyperpigmentation. You see darkening of the surrounding wound, especially in chronic wounds where there is recurrent or persistent stimulus present. Now, contractures, patient might have contracture, especially when it involves flexural area. When there is contracture, there will be limitation of function of that limb that is involved. There could be wound dehiscence where there is breakdown of wound following infection or increased tension or pressure. If it's an abdominal wound, intra-abdominal pressure, maybe from chronic cough, chronic constipation, increased pressure from tumors, ascites within the cavity. It can lead to breakdown, or this can be from local factor when you are not placing the sutures appropriately to close the wound. There will be wound dehiscence, okay, which could be partial or complete disruption of all the layers or part of the layers of a wound. There could be neoplastic transformation. When a chronic wound transforms into a malignancy, it is called Majoline's ulcer. Okay, and this is a form of squamous cell carcinoma. And this is the reason why any chronic wound that presents to you, you must take biopsy for histology to rule out malignancy. And the typical squamous cell carcinoma is different from the Majoline ulcer, because in this Majoline ulcer is a malignancy that arises from an old scar, a chronic wound. So there are no lymphatics. So spread is usually local. While in squamous cell carcinoma, the lymphatics are still intact. The spread can be via lymphatics. Infection, wound can become infected. If it's a surgical wound, it forms surgical site infection. There could be implantation, cysts, and we have an unhealing wound. Now, your further reading is very important. You read about wound healing in bones, the peculiarities of wound healing in bones, wound healing in fetal tissues, wound healing in cartilage, wound healing in nerves, as well as wound healing in tendon. What you need to know, please, you go and read about this. And wound healing in fetal tissue, they have scarless wound healing. They heal without scar. The fetus, when they sustain injury, they heal without scar. If you do an uterine surgery, fetal surgery, and after delivery, you will not see the scar because they have a thermoneutral environment. They a very good, because of the environment, no any source of infection, adequate temperature that is required for wound healing, okay? There's reduced inflammation because all their inflammatory cells are underdeveloped, they are immature. So, and you know, the extent of inflammation correlates with the extent of scar formation. That's why if you have an infected wound, they usually come up with an ugly scar. Okay. Now, there are some certain growth factors. Okay. There are some certain growth factors that are absent in fetal wound, like the transforming growth factor beta, the insulin-like growth factors. All these factors are responsible, they are notable in scar formation, okay, and they trigger a lot of inflammation. So the absence of transforming growth factor beta aids a scarless wound in the fetus. And also their matrix, their wound matrix. Okay. They have a lot of hyaluronic acid expression, hyaluronic acid expression in the fetal wound, and these aid in disappearance of any scar in a wound. So we've come to the end of the lecture. I'm going to entertain question and answer session. So wound and wound healing is a very important topic where all of us should be very, very conversant in. So if you have any question, you can unmute yourself and ask. Thank you very much.
Please, sorry, sir. Examples of untidy wounds, sir. Earlier, sir. I missed because you were fast. Untidy wounds.
Yes, untidy wounds. You see, we said wounds could be tidy or untidy. Now, untidy wounds, they are crushed. Wounds following trauma are all untidy wounds. Avulsion wounds, lacerations that have devitalized tissue, contaminated wounds, they are all untidy wounds. Hope that is clear. Following trauma.
Yes, sir.
Yes.
Yes, sir.
So that is it. Yes, any other question?
Good afternoon, sir.
Good afternoon.
Thank you very much for the presentation. Sir, my question is, when a patient presents with an injury or a wound, especially the superficial wounds, so what should be your initial response? That is, how do you treat superficial wounds? And then my second question is, what is the use or the effects of these people normally do? That is application of antibiotics, especially amoxicillin, on open wounds.
What do you say? Ampicillin. Okay. Now, the management of wound depends on the type of wound. That is the essence of classifying wounds, whether superficial or deep. Okay. Now, you should know when a patient sustains injury and patient is bleeding following trauma, that management is, of course, different. You have to follow ATLS protocol in managing trauma patient. When they present to the emergency room, you secure hemostasis by pressure packing, limb elevation, okay? Application of sutures and all that. That is to secure bleeding. And you follow all the protocols, ATLS protocol, ensure patent airway, is breathing normally and circulation and all that. Now, but when they present with wound that is not maybe bleeding, that is superficial wound, the management of that wound depends on the type of the wound. Now, we said wounds are classified as clean wound, clean contaminated, contaminated, and dirty wound. And this classification is based on two factors: risk of infectivity, okay, and degree of contamination. Now, how you treat that superficial wound depends on the degree of contamination. We said when it's clean wound, the risk of infectivity is less than 2%, 1 to 2%. Okay? This is clean. There is no any contamination. It's a surgically incised wound. There is no breach of asepsis. Okay? Infection rate is less than 2%. Okay? So how will you treat this? You just suture it. If it is, we say this is surgically incised wound, the edges are well apposed. You just use your suture to suture it. Okay? When it is clean contaminated, in clean contaminated wound, the infection rate is 5 to 10%. If a superficial contaminated wound present to you, you don't suture primarily. You commence dressing with antiseptic agents, okay? Antimicrobial agents. You dress. Why do you dress? You want to allow for a delay primary closure so that the edema and inflammation and infection subsides in 5 to 7 days or 3 to 5 days. When the edema subsides, you now close, okay? So you can see it depends on the degree of contamination. In clean contamination, here you close primarily. Here you do delay primary closure. Now in contaminated wound, okay? In contaminated wound, you also do the same as above. The risk of infectivity here is about 10 to 20% or 10 to 30%, okay? In contaminated wound, there's contamination here. Now, if this is following trauma, maybe, and is less than the golden hours, let's say 6 to 8 hours of presentation, someone sustained trauma and he present to you, the wound is dirty, okay, but he present within the golden hours. You just debride the wound, clean, remove all the vitalized tissue, and you can close primarily because it's within the golden hours. But if patient present after 8 hours, you have to do a delay primary closure. You just dress, ensure you secure hemostasis, pack the wound, and you dress daily for like 3 to 5 days. When the contamination subsides, you get rid of the contamination, you now close. Now for dirty wound, it is already infected, whether it's superficial. It's already infected. You never close a dirty wound. You just keep on dressing with an appropriate antimicrobial agent until the wounds become clean. How do you note a clean wound? It will have a healthy granulation tissue. A healthy granulation tissue is not discharging pus. It has a pinkish bed, pinpoint hemorrhages, okay? And sometimes you see a clear serous fluid. Then in that case, if it's a wound that you can undermine and close primarily, you do that. If you cannot do that, you now do a tertiary closure where you get a graft or a flap to close the defect. So you can see the treatment of a superficial wound is not the same depending on the type of wound. For dirty wound, the infection rate, the risk of infectivity is up to 40%. So it depends on the type of wound that presents. That is regarding your first question. Then the second question, where you see people applying ampicillin powder directly on wound, that is wrong. It's not a correct practice. You see all these, what do you call these chemist men? Don't ever do something like that. It's totally wrong. You don't just go and, in fact, that drug is not meant to be applied topically. Topical medications, in fact, you don't apply chemicals directly that are in form of drugs like that are compounded into drug on tissues, because they cause tissue injury and a lot of inflammation. So what you apply on wounds are specially made. They are dressing agents like povidone iodine tincture, use Savlon to dress wound, normal saline, hebetane, chlorhexidine. So many dressing agents are what are used to dress wound, but you don't go and get a drug that is meant to be swallowed. You now open maybe a capsule and start applying that. You know, that is wrong. So don't do that. There are agents that are meant for topical application. And some of even these agents, they are not even apply on in open wounds. Okay. So hope this answers your question. Any other question?
Sorry, sir. Please, sir. Earlier, sir, you said some criteria when a dirty wound become clean. You said it has to be pink, serous.
No, that's
I
regarding
forgot.
a granulation tissue.
Okay, sir. So granulation tissue. Okay.
There are criteria for healthy and unhealthy granulation tissue. Okay. So you have to read about granulation tissue, healthy and unhealthy granulation tissue. Yes, any other question?
Yes, sir.
Yes.
Yes, sir. What about applying hydrogen peroxide in a open wound, like when dressing it?
Okay.
Yes, you know, I told you are dressing agent. Hydrogen peroxide is also a dressing agent. Now, the agent you apply depends on the type of wound. Okay? Hydrogen peroxide is also a dressing agent. Okay? But it is applied on a dirty wound, especially wound that is polymicrobial, that has both aerobic and anaerobic bacteria. What the hydrogen peroxide does, it releases free hydrogen ions that destroys the anaerobic organisms. Destroys the anaerobic organisms. Okay? What the hydrogen peroxide does, it releases free oxygen ions that destroys the anaerobic organisms. Okay? That does not survive in oxygen. You use hydrogen peroxide. It's a topical agent it's a topical dressing agent, especially for dirty wounds, polymicrobial wounds. Now, there are several dressing agents. Okay, we talked about hydrogen peroxide that releases free oxygen ion to destroy anaerobic organism, especially in polymicrobial infection. You use it to address abscess cavity. You have iodine. There's the povidone iodine. That contains, it contains iodine, and this is used for wound dressing, of course, skin preparation during surgery, and this is different from the iodine tincture, you know. This iodine tincture, when it's applied on wound, is very painful because it contains methylated spirit. Iodine tincture is a combination of iodine and methylated spirit. Why this is just iodine of various percentages, 5%, 10%. So this one is painless. So use it in wound dressing. However, the disadvantage of povidone iodine, it is easily and readily denatured. It is denatured by body secretions. So if you have a wound that is discharging a lot, you don't use povidone iodine to dress because it will denature the active iodine component. You use normal saline for wound that is healing. Okay, so that you don't, if you go and use hydrogen peroxide for wound that is already granulating well, epithelializing well, it will disrupt that normal process. So you use normal saline for healing wound. You use honey. Honey is also a dressing agent, bactericidal, bacteriostatic, okay, containing substances like inhibin that inhibits growth of bacteria, okay, and several other mechanisms of action. You have okay, you have there are several other dressing agents. Now, these dressing agents have their particular characteristics and the type of wound you use in dressing them. You can't just be using all form of dressing agents. So you need the knowledge of what the component is, what are their mechanism of action, what are the more appropriate wounds you use to dress, and what wounds are contraindicated. Yes, any other question? Yes, any other question? Okay. I believe there is no any other question. So if there is no any other question, we are going to stop the lecture now. Thank you very much for participating.
Thank you, sir.
Thank you, sir.